So now we've covered the front, the side, let's turn the head this way, and now we're onto the back. So now we're into the prone position. And that's when we want to get to something really on the back of the head. Posterior fossa, midline, anything in the parietal, before the parietal boss, anything, essentially anything from the sensory strip on back, down the back of the brain here. So this is the full prone position. We have the patient on 2 chest rolls, and that keeps the chest free. So again, there's good venous return. How many times have we said that? It's all about venous return and keeping the head above the heart and keeping that brain relaxed. We have the knees well padded, we have the legs up a little bit, and the reason for that is we're going to want to put this table in reverse turned over, and we're going to do that in a second. The pins go on while the patient's still supine. So we'll put the pins on while the patient's in the hospital bed, then turn them onto the operating room table with the pins on already into the prone position, and then fixing the pins. That's important too, and then the hospital bed gets wheeled away, and then the reverse happens at the end of the operation. You bring in the hospital bed, you keep them in the pins, you detach the pin from the holder, and then you rotate them onto the hospital bed and then remove the pins. This looks like a pretty straightforward position. How can you mess this one up? Well, as we said, positioning is probably one of the hardest things to learn, and sometimes you learn by hard experience. So what you want to do here, though, is again, it's about that angle of the tentorium. If you have the patient with their neck extended like this, you cannot operate this way. You're going to you're going to have to operate like this to get up towards the top of the posterior fossa. So you really want the patient flexed. And this is where variation comes in. Some people believe in military flexion, pulling them up this way. They like that. I'm more one, especially if it's a long neck and a young person, I like to flex the neck down and then make up for it by bringing the bed up. So look what happened when we did that here. There's a mistake here. And this is the critical point. That chin has to be free. So we position the patient too far down on the bed. So slide on up. If only our real patients could do this. But that's the key thing, is you want to have them off the end of the bed. Now I can flex the chin, and it's away from the bed. And most important is that's critical, because when I go to reverse Dellenberg, watch what's going to happen. The patient's going to slide down the bed. But even though they're fixing the Mayfield, they'll still come a little bit closer. And then all of a sudden you've got your chin too tight to the padding here. And I've seen patients wake up with necrosis on the bottom of the chin because it's against the edge of the table. You want to get that all padded. If you're worried at all, you can even get egg crate in there under the chin so that they're well padded and everything's taken care of. You can see what can happen. We can put them in reverse in Dellenberg. We can lower the table now, and they're in a perfect position for us as far as we're concerned. They're flat. We've got them flex enough that the posterior fossa is flat. We can operate this way. We can come around this way. Another way I like to use this position with a variation that we'll show you in a second is to operate from down there. But most common is to have them like this. If you're going to do posterior fossa surgery, we'll do it with the scope set up like a spine position. So surgeons are on either side and can operate looking up. So if you think about it, the left-handed surgeon can be here and operate left-handed looking up, right-handed surgeon over there. But the key things on the prone position is getting that head flexed if you're going for the cerebellum. Tilo-velar approach is going up to the top of the fourth ventricle. This is critical. If you have the head too extended, you'll never be able to get up. And by the time you get there, you'll have your microscope against the patient's back. The key thing is having that head flexed, watching that chin, making sure you can pass a hand under there, and then again, using reverse Dellenberg to get that head above.